To hit a bit of critical mass here, so let's get this moving. I'll just do a quick brief introduction and then Dr. Harris, you can take it off. Welcome everybody. Welcome to another installment of Dr. Brian Harris's monthly masterclass. Once a month, the first Wednesday of the month, Dr. Harris will be on here at this same time, answering live Q&A. We will always record these so that way you can watch it back later. Those videos will be posted up on our YouTube as well as available inside the clinical lounge. But just briefly want to plug the Neer Clinical Lounge. Dr. Brian Harris is in there as well as many other super experienced cosmetic dentists that are using Neer. Use it as a tool. Post your questions. We're here to help. And with all of that, I'm going to hand it over to you, Dr. Harris.
Awesome. Well, hey, it's good to be here with everyone. I know there's other things we could be doing with our Wednesday evenings. But I find these, this 1 hour at the start of every month it's helpful, I think, for at least it's helpful for me, and hopefully it's helpful for you guys to be able to just have an open dialogue about what it means to be doing no prep veneers, no prep printed veneers, and minimal prep printed veneers in your practice. And so, this is the fastest growing segment of cosmetic dentistry right now. It is here to stay. It is going to just continue to get better and better. And so, obviously you guys are here tonight because you see that too. And so the whole purpose of this time together is to help get everybody as comfortable as possible so that when you sit down to do your next case, you can do so with confidence. There's no ego on these calls. Everything, we'll talk openly about everything. If I share something that you feel you disagree with, it's okay. Like, speak up. We'll talk through it because there's always various different ways to do things in cosmetic dentistry. So it's good to have you all. I'm going to jump in. So what I like to do on these calls is I like to start with first sharing a marketing tip or trick, something that I'm actively using in my practice right now to attract more smile design patients. It's one thing to come on here and talk about the stuff and understand clinically how to tackle these cases. What I want everyone to also understand is how to get more patients like this in your practice, because that's really the thing that we want. It makes no sense to know how to do this if we don't know how to attract the right types of patients to treat. So there was a conversation this week that we had at Neer about Moment, and specifically for those that have not used the Moment product yet, it is a 3D printed smile test drive, essentially. So smile test drive is something that I developed in my practice that I've been teaching for a number of years, where we use flowable composite to build up a smile and show patients what things could look like. And it takes me about 45 minutes to do 10 teeth. And it's great, but it's time intensive. It's very technique sensitive. And Moment allows us to just take a quick scan, send it in, and patient comes back in. You can pop this in, and they get an immediate chance to see what their smile could look like. Excuse me. And so it's not a lot of time in the chair. You really don't need to do much of anything at all other than take a really good scan. It gives the patient a chance to see what their smile could look like, but more importantly, they can take it home. They can pop it in and out. They can, they have something of value that they can take home and see what this new smile is potentially going to look like. And it's not going to last forever. It will break eventually, and so don't worry about them taking this and then not moving forward to treatment. But it gives you a chance to show patients what's possible. So a couple thoughts with Moment. At least in my practice, when I am using Moment, I will bond it in place. Or I'm sorry, I will place it. I won't bond it in place. I will place it. And then I almost always will take a little disc. I use the 3M soft flex discs. Just there's coarse, semi-coarse, fine, and then there's one that's orange, that's just under the semi-coarse. And I use that. It doesn't take hardly anything off, but it allows me to kind of even up edges, open embrasures, just make things as ideal as possible before I let the patient see the moment. So if you are not using it, it's absolutely one of the best ways to enroll patients in treatment. Let them visualize what's possible before um, before they have to commit to something. So there was a lot of conversation this week about what doctors should be charging for moment. And I was thinking about the best way to answer this, and I think there's two ways to think of this. One is like, okay, I'm going to buy a 5-pack, so they're $100 each. Well, traditionally in dentistry, we want to try to charge like at least 3 times the cost of a lab fee for something to be profitable. So I'm going to charge patients $300 or $400 for a moment, and that's kind of the traditional way of thinking about something like this. The problem with that thinking is that now you have created a barrier between you and the patient getting what it is that they want, because now they've got to come up with $300, $400. Let's even say $200. Let's just say you double the cost of the lab fee. It's still $200. And most of us, even if money's not an issue, most of us are going to be like, is it worth paying $200 for something that is temporary, that's not going to be permanent? And some wouldn't think twice about it, they'll do it. But I will tell you, it's a barrier for a lot of patients. And it's not that they don't have the money to pay for treatment. It's not like, well, if they're not even going to spend $200 or $300 on a moment, well, then they for sure can't afford the veneers. It's it's just that, something that is um, so temporary, sometimes people have a problem paying for things like that. And so I would challenge you to think about it differently. Right now, we will send out a mailer, or we'll run an ad um, we'll do Google ads, run it out on the internet or on social media, and we're going to do like exam, X-rays, cleaning, $99, or we'll do free whitening for life for every new patient. And you think about those offers, exam, X-rays, and cleaning, and then you discount, like, instead of it being $250 or $300, you discount it to like $100, and that's what the patient pays you. So you're giving up so much value, but then you're attracting the types of patients that are always going to want a discount. But you are giving away, you're paying something to get that patient in the door. You're paying, whether it's in your AdWords spend or it's the lost revenue, you're paying something. I I do not charge for a moment in my practice. My philosophy is, hey, if a patient wants to see what's possible, I will absolutely order the 5-packs, and I'll let people go through the process, and we'll have a moment made for them, and they'll get to wear it. Now, I do ask them that if they're going to go through that, and if we do it for free, that they let me take photos of it, that they let me post it on social media. But if they're willing to do that, then we give it to them at no cost. And the reason we do that is, it closes cases. It just does. When people can see what things could potentially look like, they're so much more likely to sign up for treatment. And so I I almost don't even have a fee for it in my practice. It's just something that, every cosmetic consult that comes in, or if there's a patient out of hygiene that's interested in doing something with their smile, we'll allow them to go through that process for free. And it creates amazing content. It gets emotional buy-in that they can go home and show their spouse, and it just separates you from other dentists in your area. Okay, so that's my quick marketing message about how we should all be using Moment. Um, I want to open it up to any questions
We
that
got
anyone on the call has.
we have two right now. One actually related to moment came up. Do you give your patients any instructions for like care or cleaning with the moment?
I'm sorry, I'm getting over a bad cough. I missed that. For care or what?
Care or cleaning, anything like that with the moment?
No, I don't, because I almost don't want them to think about it as a long-term solution. And at least in my experience, you know, in the old days there was snap-on smiles that were really thick and bulky, and they're less likely to break, but I feel like they talked people out of moving forward to treatment because it just looked way too artificial and fake and bulky and bright. The thing about Moment is that it's very lifelike. It can be very realistic. It has a translucent nature to the material, and it's a much thinner product. So the chances are, after taking things in and out many times, it's eventually going to break. It's meant, for just a moment, not long term. So I don't even give them any advice on that. I just tell them like, hey, this is for you to wear around for the day. If you can get it to last longer than that, great. Just be careful, get it to last as long as you can. But and I also tell them that the purpose of the moment is to let them see one idea of what's possible. And from there, then we can decide how we want the actual nears to look like, or what we want them to look like. So the reason I do that is I don't want people to immediately just think like, oh, because the moment looks like this, then the veneers are also going to look like that. When it's all one piece, it's more likely going to look more bulky. And so before I even let them look at it, I always downplay it. I just say, hey, this isn't perfect. It's just one idea of what's possible. So let's use this as a starting point. Let's talk about what you love, what you would want to change. And that way, when we actually do move forward with your case, that you get exactly what you want in the end.
I like it. Another question coming off a moment. Do you scan the moment after you have it polished, it before the patient leaves, in case they break it?
Yeah, you can. I mean, Near could always just reprint the new one. The benefit of scanning is, to communicate with the lab. Like, let's say you do a moment and you're like, this is amazing. Patient loves it. Everything's great. Then I would just, communicate that to Near and say, hey, when we actually designed the case, the length was great, general shape was great. Let's just make a better version of the moment. Um, but let's say you tried in and the moment was too big, and let's say it was too long, or you open up some embrasures. Yeah, you can reshape it and then scan it and say, this design is more ideal. And then when they go to actually design the case, they can use that as a reference.
And then last question, will Near ever do less than 10 units?
Yes, and it depends on the case, but yeah, we had one recently where post ortho, the premolars were kind of flared out, where they're actually like in a perfect position, but then the canines were angled in, and the rest of the front teeth were small. In those cases, it makes more sense to do six teeth. I would say most of the time, it makes the most sense to do 10, and we'll go through a couple case examples here shortly.
Yep. And then I can just add on to that, from like a Near perspective, you can always request based off of the patient's smile, what's going on, what you're trying to achieve with the patient. We only want to do 6, 8, or 10, right? Just put it in your case notes. We actually have a teeth number selector so you can uncheck the teeth that you don't want, and that will signal to the design team of what they're designing. We still keep the flat lab fee. Most of that's just to help cover us in our productions. But you can request any of that and just let the design team know what they need to deliver.
Right.
I think that's all the questions for right now if we want to keep going, Dr.
Okay,
Harris.
let's do it. So, some awesome cases recently posted on the WhatsApp group, and I want to just take some time and go over these cases. But I have a couple rules. You know, there are many doctors on this call right now. There's going to be, 10 times as many doctors watching the recording of this. Every doctor has a different philosophy of how they treat, what they're comfortable doing, what they think is aggressive versus what's just normal every day. We all have different patient populations. There's some on this call that are small town, like you're the dentist, the endodontist, the oral surgeon, like you do everything. And the benefit of that is your patients trust you. They're likely to understand if you say, hey, this is a little bit risky, maybe this isn't the best case for Neer, but let's give it a try. I think it could give us a great result. Maybe it only lasts a couple years and then we can do porcelain down the road. You've got some of you have patients that absolutely trust you, that have been with you for 20, 30, 40 years even. And you're going to be able to get away with more than a dentist that's 2 years out of school, as an associate in a brand new practice where it may not make sense to go and do, a more aggressive Neer gaze. Now, when I say aggressive, I mean, there's risks with any type of no prep dentistry. There's risks, just like there's risks with prepping teeth. There's just different types of risks. Okay, so in a 10-unit porcelain veneer traditional prep or at a 10-unit crown prep case, the risks are sensitivity, pain, changing the bite, gum inflammation, TMJ issue. There's all sorts of things related to traditional smile design or porcelain crown smile design, right? But you don't have the issues of necessarily of like fractures, things breaking, as many functional issues because you're building into a strong porcelain system. Now with Neer, you don't have those same issues of sensitivity, as many issues with pain, but you have more issues with potential fractures. So you just have to understand there's a trade-off, and I think they're equally as stressful. But it's you can essentially do Neers on any patient that you choose to. You just need to understand your risks. So I'm sorry, that's a long-winded way of saying I have two rules. As we go through these cases, number one, I'm going to tell you whether or not it's a case that I personally myself would do with Neer. And then I will tell you if it's not a case that I personally do, I will still tell you how to go about doing it if you wish to do it yourself with Neer. Okay? Good. Okay, first case. So when I look at this, I think, okay, there's some functional issues, chipping of the front teeth, overall, generally healthy teeth, some crowding on the bottom, some teeth that are out of position. This could be the reason this is breaking. But overall, I look at this as like, hey, this could be a decent Neer case. So then we look at how his teeth come together. Now we can see why this is fractured here. We can see why things are worn down. This is a very tricky case. Now, would I do it in my practice? I would. If the patient was, if it was purely a financial decision and they were looking for something to get them by that would look great and still last relatively a long amount of time until they're ready to do porcelain, I would consider treating this case. But before I do that, I would prep some teeth. Without any anesthetic, I would do minimal preparation, but I would be reshaping enamel before I did this case in Neer. Okay, and this is going to seem aggressive to some of you, but I call it, conservatively aggressive. I'm not going to go in and grind all the teeth down and prep things to little nubs and then cover them with Neers. No, we're still going to keep the Neer portion, as minimal prep as we can. But I would absolutely come in here and I would take a disc and I would shorten and even out these lower anteriors. Okay, so shorten 23. I would polish the facial of 24 with the red striped diamond burr. I'd flatten it up. I'd even up, 20, 25, and same thing on 26. I basically would do enamelplasty on those lower anteriors, smooth things out, get everything to look nice and straight. And that would give you more room so that you could do this with Neer and have some more clearance. So you can wrap those incisal edges a little bit. I would also use a disc and shorten the incisal edge on some of these front teeth. So yes, we're gonna take away enamel. We're gonna take away healthy enamel with the burr, with the disc, but we're essentially creating a little bit more space so that we can then cover the teeth with Neers and have less chance of a fracture. Would I do this case in Neer without doing what I just told you? Absolutely not. There's just not room for you to be able to do that. Now, there's always the question of, well, why don't you just do Invisalign or ortho first? 100%. Absolutely. That should always be option number one. Straighten the teeth first, give yourself some space, then come back and do Neer. But you're going to have those patients that aren't going to want to go through that. So then you just have to make the call. Either just agree just not to treat them, or if you're willing to take the risk, then do some enamelplasty first. Okay, so when you look at the rest of this case, chances of something fracturing or breaking, and look at some of these fractions up here, there's a lot of forces on these teeth. There's a good chance you're going to break something. So as long as the patient's aware of that, and as long as you're aware of that, and they're willing to take the risk and you are, then have at it. Questions on this case?
Feel free to type out your questions. You can also raise your hand, and we're happy to unmute. Um, any questions at this time?
Okay.
Nope.
Say come up, just ask.
Yep.
Um,
Oh, do we have a final photo for this case? No, this is actually a doctor that was trying to see, I think, if this was a potential case today.
yep. All of these cases that we're going to go over are potential cases for many of you that reached out even just today or yesterday. Looks like there was another one in there.
I think it's just the doctor that posted this
Awesome.
saying thank you.
Okay, Natalia. Yeah. If as it gets closer, if you have additional questions, um, reach out. So as far as that's a great question. Okay, this is marketed as a no prep process. Yeah, so let's have this conversation. I would say, and this is I'm going to tell you this right now. This isn't a bait and switch. I do not believe in marketing no prep and then they get in the chair and you're like, actually we have to prep. Neer is a no prep process. It's best for cases when it's done as no prep for the right types of cases. And so the way that I handle this is if I'm marketing a no prep or minimal prep process, great. Patients can come in, and when they come in, then I say, hey, you are a candidate for Neer. However, this falls under the category of what we call minimal prep. If we do this without prepping anything, um, it's going to be impossible to do that because of how the teeth function. And you're a candidate for Neer. You're just not a candidate for Neer no prep. You are a candidate for a Neer minimal prep. And here's what that means. We don't need to numb things. We would need to reshape some things. The benefit of reshaping is cosmetically, it's going to look better in the end, and it gives you room so things are less likely to break. So as long as you're comfortable with that, let me kind of show you what that would mean. As long as you're comfortable with that, then yeah, we can move forward. And if you're not comfortable with that, then we have two options. Either we don't go the Neer route and we do this as a prepped porcelain veneer case, or we go through orthodontics first, and then we can come back and do it as a no prep case. My experience is that most of the time when patients are wanting no prep, it's not that they're wanting absolutely zero prep. They just don't want all their teeth ground down. There's some level of anxiety or fear, or they just really want to be conservative and not take away enamel. So just let them know they're still a Neer candidate, but only if it's a minimal prep Neer case.
It's a great question.
It's really good. I've heard people say, it's like, oh, I'm just going to mark it no prep, and then they last minute switch on the patient and say, we're gonna prep the teeth. That's the fastest way to really upset people. The best thing is just be completely transparent and honest. And I actually, the verbiage I use with my patients is like, hey, technically, we could do this case no prep. We could make veneers. We can put veneers on anything. It's just a matter of like, is it going to function and is it going to last a long time? And in this case, no, it won't. It would break really soon. Okay, next case. Okay, super, super tough case. Um, for a couple reasons. One, when these patients come in and their teeth are already really flared out and the smile is narrow, you can do minimal prep dentistry in these cases if you extend back further and do at least 10 teeth. The fastest way to get rid of that flare on the front is going wider and then just making it look like, the flares in the appropriate space within the smile. The tricky thing with this case is that, it has wear on the edges. Okay, this shows a little bit better. But it's that overjet is out pretty far, and there's some overlap with some of the other teeth around it. So you've got some overlapping of teeth. It's really flared out. To do this as a no prep case, really tough. By the time you finished everything out, it's going to look really, really full and flared, and the lip's going to have a hard time coming over it. So I would absolutely not do this as a no prep case. I would be very cautious to even do this as a minimal prep case because you're going to have to bring back 8 and 9 pretty far. And then if you look closely here, you've got a crown on this one here, and you've got a crown over here too. And so, to really do it right, you're going to want to widen the buccal corridor. And I would not recommend bonding these over existing crowns. You can. I've done it before, and I don't have any stress around it. But if patients are paying for it, and there's risk of it failing, I just don't think that's, it's the best option. It's just too hard to get a good bond strength to those materials. So I would say this is not a case that I would treat with Neer personally. And if the patient was in my chair because that's specifically what they wanted, and they wanted to be no prep, and the budget only fell within what they could afford with Neer, then I would say, okay, I'm willing to do this. But the way we're going to do this is I need to at least shorten these front teeth a little bit and at least prep away some of the enamel on the front. We can do it without getting you numb, but we need to bring some of that back so that we can get the most ideal result possible. And just, try to get as much enamel removal that you can. But frankly, what you don't want to do is you don't want to start prepping the enamel, then it still looks really thick, and then you can't really go back after that. So I would say this is when I would just talk into traditional veneers or ortho first. Okay, any questions on that one? Sometimes we think it's like, oh shoot, they came in for this consult. What now? Now I got to tell them they're not a candidate, and it's a conversation that needs to happen. And so, I always just lead with like, hey, we can do whatever you want to do, but it's just a matter, is it worth going through the braces, possible surgery, is it worth going through all that and then doing near after, or are you better off like in a case like this? I mean, frankly, she's almost better off if it's primarily these front ones. I would do, 4 traditional veneers or 6 traditional veneers, at a lower fee than to do, 10 Neers with orthodontics, so just don't be afraid to have open conversations with them. Okay. So the comment on this case was, he just really wants white teeth and he's not willing to go through ortho. So, um, I can't actually, let me see if I have the bite case on this. I don't. Okay. Um, I can't tell how the teeth are coming together, but let's just assume that he's got decent occlusion. Okay. In a case like this shows it a little bit better here. Um, this this is tough because you're going to go no prep on 8, 9, and then by the time you bring 7 and 10 out, you got to make them really thick to do it. Now it can be done. Um, I would say if I was going to do this in Neer, I would at least polish back the distals of the centrals a little bit so the veneers can fit there. If not, then the veneer ends up being thicker here, and then it's going to encroach on the width and the fullness of this, and it's just going to look really thick in the end. So I would say for sure some simple enamelplasty just to make room for the veneers. Now, this is also a type of case where um, I do this often on almost every smile design case I do. If they're only doing the uppers, I will come back on the lowers, once tempers are in place, and I'll just polish and size the ledges, even things up, whiten the lower teeth, and get them to match the best they can. And then it also helps you with clearance on the occlusion on the interiors. So I would say yes, it could be a decent near case, but it's going to be hard to do this without it looking really bulky. Um, when you see the angulation of some of these side teeth, if you're not doing any enamel removal at all, remember you go wider on those sides, and then it's just going to be thicker in this area. So, um, tough case to do with Neer. Any rebuttals on that? Questions on that?
Doesn't look like it. Again, just a reminder, feel free to either raise your hand and we can unmute you, or just drop a question in the chat if you don't feel like talking. Any question goes here. Same with, in the clinical lounge, there is no question too small. Like, we want to make sure, or comment or anything, really. This is a discussion.
Okay, keep going. Awesome. Thank you. Have a good night. That's not to all you guys. That was just for the one who just commented.
We actually have a good question here. Dr. Harris, what do you tell patients that want to do the lower teeth as well?
Yeah, I let's do this case as an example. I would not mess with it. One, we're not there yet with Neer where we're doing lowers. If it's small teeth spacing, if it's like the perfect no prep case that it's like they're just born with small teeth, then it's yeah, you can consider doing it. But I would say that, having done a handful of lower arches in a no prep printed resin, it's a lot of work and it's a lot of stress. And the difference between the uppers is it's uppers. It's mostly for looks. There's still function. Once you start doing the lowers, you have to do all the teeth. Now you have to open the bite, and in most cases, and now it's all function on the 3D printed veneer. So I think there's too much risk. If you're a doctor listening and you do a ton of full mouth rehabs already, then you would know exactly how to manage it. I'd say have at it. What I tell all my patients is what seems to work best is whitening the lowers, reshaping the lowers. Let's start with the top, and and that's usually going to be good enough. If they want, color match everything to be nice and bright, then yeah, I would move them more towards porcelain.
We actually have a couple questions here. One's going to be a case review. But before that, if we need to remove a near, what's the best way to do this? Is it laser? Is it handpiece? Level of complexity. how do you go about that?
Yeah, if you have a laser, great. Use a laser. If you don't, handpiece is great. I always just, I mean, most likely you're not going to section this thing and pop it off. Once they're bonded in, they're bonded really, really good. So what I would do is start with just like a regular prep diamond, take off, that initial outer layer. And then as you get closer to the tooth, then just switch to like a red stripe diamond burr and just slowly polish it away. I mean, it's the only way to remove it really. But yeah, just diamond burrs, laser if you have it. But do not try to section them, with a line down the middle and then crown separator. I would not do that. There's more risk of notching the incisal edge or the enamel. And there's more, usually what happens is you start that and then it doesn't, and then you got to go and prep it off anyway. So just slowly prep it off. Okay.
Right. It looks like there's a another case. I
I'll
don't
come
know if
back to
you
this case. We'll do that one at the very end.
great.
Okay. Okay. So narrow buccal corridor. There's a cant, so everything's kind of off to one side. Um, I immediately look at more like number 10 area where it already looks really small and it's kind of set back a little bit. Okay. Bite wise, I'm looking here. Yeah, some areas are kind of tight, but overall, I look like healthy teeth, good teeth. Like this could be a good case. The tricky thing in cases like this, where there's some deeper embrasures here, on patients that have some recession, there's deeper embrasures, kind of getting things to flow into those embrasures can be tough. And essentially there's undercuts there. And you can see that because, see how here we weren't even able to fully get this scan here because of the undercut. So that's going to be more difficult. The most difficult thing with this case is going to be getting this forward without making it look even more narrow. So if you did this as like a true no prep case, remember the Neer's got to sit kind of on the outside edge here. And that means that that's going to encroach on 10 a little bit. And so it's going to make 10 look even a little bit more narrow. So this is one where I would say if you could polish just a little bit on the distal here to give room to bring this one out more and have it look normal size, that would be ideal. The most difficult thing for this case though is going to be the deeper embrasures in designing this case. Does that make sense to everybody? So it's these areas in a no prep veneer, when there's recession and you start getting these areas where at the cervical everything's kind of more triangular shape and undercut, it's really hard to get the veneer to fit on there without leaving some area exposed on the actual teeth. And so you can still do it, but usually that's where I'll take a burr and just kind of open up the embrasures or a disc a little bit just to get the veneer to fit back there. Any deep embrasures, any severe recession, it's going to be harder to do. So the one benefit is it looks like this is her bite. There's plenty to kind of wrap the incisal edge. It looks like you could get a great result from a strength standpoint. So it's going to be less of an occlusion or functional issues with this case and more fit issues when you're trying to get everything to fit without having exposed areas. Okay. This was on the other day. Again, really tough case. If it could be a great Neer case, I think they did a moment on this and it turned out great. But this is one where, I mean, most commonly when you're doing no prep cases, it's almost always the distal of the centrals. Just a little bit of polishing there allows you then to close the space, make this normal size. If you don't do any enamel shaping, it's just hard to get it to look natural without looking too bulky. So I would go minimal prep on this. I would also absolutely do some gum reshaping too. So if this patient were in my practice, she saw an ad for no prep veneers, I would say, hey, I think you could be a great candidate. You have small teeth, the arch is narrow. It can be done if you're willing to allow me to raise the tissue a little bit on these areas. It's going to give a much better result. See how small and kind of square this is. If we could raise this tissue a little bit, and then I'll have you come back in a couple weeks and we can take the scan, raise the tissue here and here. Then we can get a lot more symmetry. It's going to look significantly better. And if you'll, we can do this pretty conservatively, but if you allow me to just reshape the distal aspect of these two front teeth and maybe shorten this front one a little bit, overall it's gonna look fantastic in the end. But again, it's your call. We don't have to do that. We can just build off of what you have. But the final result is going to look significantly better if we can do a little bit of shaping. Okay. Um, Hold on. Let me see this question here.
It's, are you able to add flowable to the moment to simulate a higher gum line?
Yes, you can. I do that in my normal test drives. So what you would do is you'd seat the moment and then you just take the flowable and just kind of put it up. You're kind of going to overlay the tissue. Sometimes you just add a little bit to the cervical of the moment and um, and then cure it, and that'll kind of simulate that. As far as adding to the moment in the lab, Patrick, can we do that yet?
Um, it,
Not really,
I
right?
think would be super tricky. We could certainly try it. But right now, it's not a part of our design protocol. We design everything below the gingival line.
Yeah. Does it cost more to add reshaping? I don't. So in my practice, um, it's an all-inclusive fee. It's easier that way. And so if this patient, I'm gonna go back one. If this patient's coming to me and she's like, hey, I'm gonna move forward, let's do 10 nears. For me, it's exam, x-rays, records, any reshaping of the tissue that needs to be done, any reshaping of the enamel. It's all included in the fee, and that comes with a retainer after the fact to protect things so that there's less risk of things breaking. So it's all included, all in one fee. That way we're not nickel and diamond patients for every little thing. And as far as what the fee should be, I think it should be half of your porcelain veneer fee. We all have different fees based on our practices. I think it's it's half of your porcelain veneer fee, unless your porcelain veneer fee is really low. Like if your porcelain veneer fee is 1,000 or 1,200 a tooth, then I personally, I don't think you should be doing these at 500 or 600 a tooth. Um, I think it's a lot of work for that. I think maybe let your porcelain fee be 1,200 and maybe your near fee is 800. But don't be afraid to charge for the work you're doing.
We got one other question. If a near chips but not significantly enough to warrant removal, can it be repaired with composite or flowable? If so, what's your go-to brand?
Yeah. So it hasn't happened with near yet for me, but I had a 3D printed 10 unit veneer case that I did, and and it wasn't even necessarily that it chipped. There was an area on the printed veneer where I was reshaping and and shaping a little bit, and then it got kind of thin where I could see, some tooth structure or cement underneath. In that case, yeah, I just ended where it was thin. I ended up prepping it out a little bit, did some flowable, smoothed it out. It's been a year, still looks great. You can't tell the difference. The nice thing about these products. So if it was a near, and let's say it was an incisal edge, and everything else looked great, but it was one little area, then yeah, that's the great thing about a resin, printed resin. Before I would go I always tell my patients like, hey, we have two options. We can go and cut this off. The risk is that what we put back on here may not fit or look as good as what's on there now. There's risk of potential color match not being exactly the same. If it were my tooth, I would, I would, repair it first and let's see how long it lasts. I'm still going to note it in my chart here so that if 6 months happens again, it'll still be warranted. But I would start with the, and I don't call it a repair. I just say, hey, we have materials here that are, the same materials that we used that we made the veneers out of, and we're going to go in and we're just gonna we're gonna enhance that one little area to get it back to what it looked like before. I use Herculite Ultra flowable composite. It's the best flowable, in my opinion, as far as um, how it looks. There's a shade called, so it's Herculite Ultra Flow. There's a shade called XL1, which is a dead-on perfect match with like the bleach color of Neers. Um, and so that's what I would use.
Another question popped up. Many patients ask me how long Nears last. I know it all varies on the case, but what is a fair general answer for that question?
Yeah, so here's the way I position it. I tell my patients the best option for long-term strength, success, the what gives us the most options for size, shape, color, being able to customize things is porcelain. For those that aren't ready for porcelain yet, Near is an amazing alternative. We're a little bit more restricted on how much we can customize, and but at the same time, like they look awesome. They're going to last about half as long, and so I'll tell my patients 7 years is a good lifespan. But it could be that they only last 2 or 3. My hope is that you get at least 7. It'd be fantastic if you got 10 out of them. Um, but it really does depend on the case. And so um, I, if it's a case you really want to do and you feel pretty good that it's going to last, what I tell my patients is that's why we'll order a second set. So if something ever were to happen, it's a pretty easy thing to swap out. So you have peace of mind that even if something does chip or break, that we've got a backup that we can put in there. Okay, and then don't be afraid also to tell people, like, hey, it's a relatively new technology, and what's great about it is it's made, with some of the best materials, some of the best companies out there that make the other resins that we use in dentistry. And so I'm confident in the material, but if something does happen, let's say within this first year or 2 years, like I'll take care of it. We'll come up with a different solution for you. It just depends on how much risk you want to take. Also, if you're charging 1,000, 1,200 a unit for Nears, then yeah, you can absorb some of that cost. If you're charging $300 or $400, then yeah, you don't want to be warranting stuff like that. Okay,
Two.
great question. If we could pick the perfect candidate for our first Near case, what should we look for? Okay, I'm gonna come back to that. We're gonna end with that. I haven't done many no prep veneer cases yet. I'm still learning where reshaping is necessary. When a patient comes in for a consult and I scan for a mock-up, what should I do if the design comes back and doesn't look ideal? Can I make adjustments by polishing or minor reshaping and then rescan to have a new mock-up created without the extra charge?
Yes, you can. If you still haven't approved the case design and want to make those changes and talk through it with your patient and everybody's all on board, totally acceptable and doable. It becomes a little tricky if you approve the design. So we have a couple of videos up on our YouTube. I'll be sure to post one that just kind of goes through how to walk through the portal and do all these things. But just don't approve the design, upload new scans, and say, hey, we're making some changes. Would like to see X, Y, and Z. We've done X, Y, and Z to patient's smile.
Great. Okay, for this case, then we'll get to that last question of the ideal case. So this is one of the few cases that I would say you know what, like four, like you could get away with doing four here and have it look good. I can't see what I see back here is potential recession. I see already really full teeth. This would be one that it's going to be hard to do 10 on this and get it to fit right, in my opinion. Um, but I would say this is if Neer's willing to do it, this is one where I would say, lightly polish the old composite off. I would take a disc to the edges, just kind of flatten things a little bit. Um, and then try to do four and see if you can make that work. I would say that all of these that everybody submitted though, these are all very difficult cases to do for Neer. So let's talk about, let me go back here. Let's talk about some ideal first cases. Okay. This would be an ideal Neer case for your first case. Okay. Small teeth, narrow arch, um, yeah, tissues a little inflamed, braces just came off. Maybe use a laser, let that heal. But this is like all day long, you could do Neers on this and get great results. And that doesn't mean it's going to go totally smooth or you're not going to have, some issues to deal with when balancing the bite after. But this is a like slam dunk, minimal or no prep veneer case. Okay, there's really not anything you need to prep here. You could just scan it and send it in after that tissue's healed. This is also a good um, a good case. If you look closely, there's composite here on the edge. So what I would tell this patient is like, hey, we're going to polish this composite off. Same thing here. And then we're going to scan it. This would be a great Neer case. The only thing that I would say is like, for me in my practice, see how this is kind of rounded on the distal of 9? It might even be composite there. I would maybe polish this down a little bit so the Neer doesn't look even more so rounded, but this would be another example of a great case. You're adding width, you're lengthening, you don't have too deep of undercuts, so you should be able to get into those embrasures pretty nicely. Okay, this is also, these are all examples of cases that I would say would be good first Neer cases. This sometimes with these, when they're really angled in on the buccal corridor and they're longer, sometimes it makes a little sense just to shorten these a little bit so the Neers don't look too long in the posterior. But this could be a great case. You could just scan it, send it in. It could look great. Tough case. Okay. Tough case because everything's kind of flared out. Um, you've got spaces, but not like big spaces. But the biggest thing is the angulation of some of these teeth being really flared out makes it hard to get a natural looking result. Now, if the patient's willing to let you take a disc and just polish back the distal aspect of 7 and 10, then yeah, you could pull that off. But otherwise, if it's already flared and then you're going to do no prep on top of it, it's going to look even more flared. Again, a burr and just prepping the distal aspects. It's almost always just the distal aspects of some of the front teeth. Okay, not ideal. Don't choose this for your first case. Could be, like it could work. The biggest issue is that see how wide these are already on the sides. This would be one where 6 would actually work better than 10, in my opinion. 10, it's already full in the buccal corridor. So you do 10, it's going to look even more full. So this is one where I would say, 6 and make it blend with those premolars could look really nice. Okay. I would polish the distal of 9. I'd shorten these up. Actually, I'll show you exactly what I did. So this is what I did. So just to give you an idea, it's all without any anesthetic, but just taking this down a little bit on the distal now gives me freedom to make 10 the appropriate width. Okay, this is a Neer case. That's everything tried in. I showed this on the last call. And that's the final result. Now, looking back, if I would have just gone in and done a little bit of, if I would have raised the tissue just a little bit on 7 and 8, we could have gotten even better result. But this is immediately after bonding. It's fine. But again, don't be afraid to take a little disc and reshape to perfection once everything's bonded in. Okay, the difference of maybe a little bit bulkier, a little bit more rounded to more size appropriate. Okay, we are coming up on the top of the hour. Um, any last questions? Guys, the great thing here, let me just speak to this for a minute. I run a mastermind group. I have to make sure that I don't have any of my mastermind members on this call. Um, I don't care either way. I run a mastermind group where I mentor doctors on cosmetic cases, and they pay $1,500 a month to be part of this group. And I just before this call, we had our monthly call. We have 2 calls a month, and doctors are paying a lot to be able to show up and talk through their cosmetic cases and learn best practices for marketing techniques. You guys, because of Neer and because of being a part of this group, you guys are getting access to this for free. And I hope you understand like this network, the information you're going to get for starting off doing cosmetic cases, especially, is invaluable, but you have to get outside your comfort zone and take advantage of it. You know, post cases to the group, show up to these calls. If you're willing to put the time and effort in, you've got some amazing coaches that will show up and be there for you and help you without making you feel stupid or belittling you or questioning, how why you don't know something. This is new for everyone. The bonding protocol, case selection, most doctors, even the most experienced doctors, ask some of the most basic questions because it's new for everybody. So I applaud you for being here. It's an amazing group of clinicians, and as each month goes by, the more of these that we do, the more comfortable everybody will get. Let's start sharing successes, and also we'll talk about the failures too. That's the only way to learn. So thank you guys. Have a wonderful rest of the evening. Um, any other questions, post them to the WhatsApp group, and myself or some of the other mentors will get around to answering them. And again, thank you for being a part of Near. Thanks, Patrick.
Thank you so much. And thank you everyone for showing up tonight. We really appreciate it. We will post the recording of this as soon as it's made available and I get it up on YouTube. Have a good night, everybody, and hope to see some of your cases in the clinical lounge soon. Thank you.